Let's start discussing rheumatoid arthritis. So it's a chronic inflammatory disease. So it's a systemic inflammatory disease, primarily infecting the synovial joints. So etiology. So there is a HLA-DR association, so HLA-DR1 or HLA-DR4. Then again, sometimes EBV and mycoplasma, these agents have been implicated. So it is believed that rheumatoid arthritis results from exposure of a genetically predisposed individual to an infectious agent. This leads to autoimmunity and formation of IgM antibodies. So immune complexes are formed in the serum. They deposit in the synovial membrane and initiate inflammation of the synovial membrane, which is self-perpetuating. So pathology. Initially, the synovial membrane becomes edematous because there is inflammation, there is edema. Okay, then it becomes filled with fibrinous exudates and cellular infiltrates. There is an increase in the synovial fluid. As the inflammation persists, the synovium gets hypertrophied and surrounds the periphery of the articular cartilage to form a pannus. So if this is an articular cartilage and this is synovium, so it surrounds the articular cartilage, forms a pannus. Okay, because the synovium surrounds the articular cartilage like a pannus, the articular cartilage loses its smooth shiny appearance. So the pannus extends over the cartilage from the periphery and it burrows into the bone. Okay, then with further progress of the disease, the cartilage becomes worn off, the bone surfaces become raw, and the joints get deformed, initially because of severe muscle spasm and pain, but later because of the fibrosis. Then in some cases, adhesions develop between the layers of the pannus, leading to fibrous ankylosis and then bony ankylosis. In advanced disease, the joint capsule gets distended by the hypertrophied synovium and fluid, and the ligaments supporting the joint are stretched, leading to subluxation of the joint. So osteoporosis develops in the bones adjacent to the diseased joint. So you can have periarticular tissues like tendons and muscles becoming edematous and infiltrated again because of the inflammation, and they may rupture spontaneously. Okay. So stages of rheumatoid arthritis. So from clinical viewpoint, you have 3 stages. So potentially reversible. So that is soft tissue proliferation. So the disease is limited to the synovium. There is synovial hypertrophy and effusion, and you can't see any destructive changes on the X-rays. But controllable but irreversible. Okay, so there is soft tissue destruction and early cartilage erosion. You can still control it, but it is irreversible. So X-ray shows a reduction in joint space, but the outline is maintained. Irreversible soft tissue and bony changes. So the pannus ultimately destroys the articular cartilage and erodes the subchondral bone. Okay, the joint becomes ankylosed, usually in a deformed position. It may be subluxated or dislocated. So associated changes. Rheumatoid arthritis is a systemic inflammatory disease which can affect quite a few important organs like heart, kidney, lungs, etc. The most serious lesions occur in the arterial tree, which may be mild non-necrotizing arthritis or severe and fulminant arthritis akin to PAN. Okay, so diagnosis. See, women of childbearing age are affected. Okay, so there is acute symmetrical polyarthritis. So there is pain and stiffness in multiple joints, at least 4 joints, particularly in the morning. So this may be followed by frank symptoms of articular inflammation. So mostly metacarpophalangeal joints, especially that of the index finger, is affected. So PIP, proximal interphalangeal joints, are affected. Okay, you can have wrists, knees, elbows, ankles being affected. But in RA, you have to remember that distal interphalangeal joint is spared. So the DIP is spared. Others, so you can have PUO. Okay, especially in children. So sometimes visceral manifestations like pneumonitis, rheumatoid nodules, etc., they may be there. So see, on examination you can find boggy swollen joints as a result of effusion, intraarticular effusion, synovial hypertrophy again because that is the primary change in the pathology, and edema of the periarticular structures like the muscles and all that. Okay, and you can also see joints which show typical deformities. So you can see an ulnar deviation of the hand and fingers. You can see boutonniere deformity and swan neck deformity. Okay, so in you can say where there is flexion and extension at the DIP or the PIP in boutonniere and swan neck. Okay, and there's also something called a flexion deformity at the elbow. At the knee also there is flexion deformity if it is early, and late there is triple subluxation. Okay, late disease you'll have subluxation. Next, ankle, you can have an equinus deformity, ankle quinus deformity, and foot you'll have hallux valgus and hammer toe. Okay, so again extraarticular you can also have a rash. Okay, in signs of systemic vasculitis. So rash in rheumatoid arthritis is non-pruritic, maculopapular on the face, trunk, and extremities. Extraarticular manifestations, you can have vasculitis, so Raynaud's phenomenon, fever, PUO, again skin lesions like rash, chronic leg ulcers, peripheral neuritis like mononeuritis multiplex. Okay, you can have necrotizing arthritis. Then rheumatoid nodules, mostly you'll see on the extensor aspects of olecranon mainly. Other sites you can see on the dorsal surface of forearm, tendon, Achilles, etc. Serositis, so lung and pleura, so you can have pleurisy. Okay, Kaplan syndrome, honeycomb lung, etc. if the interstitium is involved. And heart, you can have cardiomyopathy, iridocyclitis, nervous system, again peripheral neuritis. Others, you can have Feltis syndrome with anemia, neutropenia, and splenomegaly. So all that. Alright, so investigations, radiological examination, you can do an x-ray of both hands of the affected joints. You'll find reduced joint space, erosion of the articular margins, subchondral cysts, juxta-articular rarefaction, because there is edema of all the tissues, there is rarefaction, just juxta-articular, soft tissue shadow at the level of the joint because of effusion again. So rarefactions, soft tissue shadow, and deformities of the hands and fingers, reduced joint space, all that. Blood, so you can see elevated ESR, CRP, platelet counts, etc., low hemoglobin, and rheumatoid factor. So it is an autoantibody directed against the FC fragment of IgG, and rheumatoid factor can belong to any class, okay, but commonly it is of IgM type. So you can detect it by using latex fixation test. So positivity in titer 1:20 is significant. So then Rosewaller test, or see, all patients with positive RA factor don't have rheumatoid arthritis, and all patients of rheumatoid arthritis don't have positive RA factor. This is important. Then anti-CCP, it is a blood test, so it is more sensitive to detect rheumatoid arthritis. You can also do synovial fluid examination and synovial biopsy. So differential diagnosis, it could be SLE, but the joint involvement is not symmetrical, and ankylosis and erosions are common. So ANA absence kind of rules out SLE in most cases, okay, but not in all cases. Then osteoarthritis, so the DAP is involved, okay, and you'll also have complete lack of systemic features of rheumatoid arthritis like fever, weight loss, fatigue, etc. Next, psoriatic arthropathy, you'll have characteristic psoriasis, so skin and nail changes may be present. Okay, so treatment. So aims of treatment is to first induce remission and maintain the remission. You can use drugs for this. Preservation of joint functions and prevention of deformities by physiotherapy and splinting, and repair of joint damage, so synovectomy and stuff like that. So medical treatment, you can use NSAIDs for pain management, DMARDs, okay, disease modifying anti-rheumatic drugs like hydroxychloroquine or stuff like that, okay, and methotrexate mainly, okay, and steroids, biologicals, etc. So orthopedic treatment, you can do splinting, joint exercises, operative, non-operative methods. So non-operative methods, you have physiotherapy. You will splint the joints in a proper position. You will give heat therapy, so wax bath, hot water fermentation, etc. Joint mobilization exercises, muscle building exercises, all that. So split, hint, joint mobilization and muscle building. Occupational therapy to help the patient cope with occupational requirements, and rehabilitation with the help of braces, walking aids, etc. Operative surgery, you can do preventive surgery, okay. You do that to prevent damage to the nearby tendons. So you can do synovectomy or tenosynovectomy. And palliative surgery, so you can do a palliation for, like, if there are contractures, you can do tendon lengthening and bone block operations to correct the deformity. Next, reconstructive surgery, okay, you put it back into function. So you can do tendon transfers, okay, interposition arthroplasties and joint replacement. So tendon transfer and joint replacement. So joints where total replacement is most popular are hip, knee, shoulder, etc. So plan of treatment, so if it is potentially reversible soft tissue proliferation, drug therapy is the mainstay. If it is controllable but irreversible soft tissue destruction, drug therapy plus orthopedic, okay. And advanced stage of joint destruction, drugs alone are of little use, so you will go for surgery also. So stage 1, drugs, synovectomy, okay, and joint mobilization. Stage 2, again both drugs, soft tissue repair and arthroplasty, okay, and you'll go for splints. Stage 3, you'll go for splints and walking aids, arthroplasty and replacement, and also arthrodesis, and NSAIDs. DMARDs are of no use in stage 3. Okay, and again prognostic factors, if it's a woman, more severe, age at onset, childbearing age, okay, and type of onset. So insidious onset, it progresses to severe disease. Anemia which is not responding to iron tablets, so again that is a bad prognostic indicator. ESR, CRP are elevated, bad prognosis. RA factor positivity, bad prognosis. Anti-CCP, bad prognosis. So radiological erosions, bad prognosis. Histopathological indications, bad prognosis. So then moving on to spondyloarthritis, so you'll have asymmetric involvement of the major joints, enthesopathy, so inflammation at the tendon to bone junctions, and primary spine involvement. So first let's talk about ankylosing spondylitis. It is also called Mery-Strumble disease. So it is characterized by progressive inflammatory stiffening of the joints with a predilection for the joints of the axial skeleton, especially the sacroiliac joints. So the exact etiology is not known, a strong association has been found. So, HLA-B27. So, sacroiliac joints are usually the first to get involved, okay, followed by the spine from the lumbar region upwards. So, hip, knee, mandibular joints are also involved. Initially, there is synovitis, followed by cartilage destruction, then bone destruction. There is fibrous ankylosis, bony ankylosis. Ossification also occurs in the anterior longitudinal ligament of the spine and also other ligaments of the spine. After the bony fusion occurs, the pain may subside, but the spine is stiff. Okay, that is called burnt out disease. So, clinical features: it's a disease of young adults. So, classic presentation: the patient is a young adult, so 15 to 30 years old male. Okay, he'll complain of pain and stiffness of the lower back. Okay, basically he after during sleep or after waking up from sleep, it is worst at night. Okay, so stiffness may be noticed only after a period of rest. It improves with movement, and pain is also more at night or early morning, and the pain awakens the patient from sleep. So there is stiffness and pain. So he gets better only after he walks about or does some exercises. There may be pain in the heel. Okay, there may be pain in the pubic symphysis, or there may be pain in the mandibulosteroneal or costochondral junctions. Okay, so later stages, there is kyphotic deformity of the spine and deformity of the hip also. So unusual presentations, you can have involvement of peripheral joints like shoulders, hips and knees, and sometimes it may present with chronic inflammatory bowel disease. So on examination, you will find a stiff spine. So there is loss of lumbar lordosis. So lumbar spine flexion may be limited. Then test for detecting sacroiliac joint involvement. So first, tenderness. So localized to the posterior superior iliac spine or deep in the gluteal region. So PSIS tenderness or gluteal tenderness. Then sacroiliac compression, direct side to side compression of the pelvis. It causes pain at the sacroiliac joints. Then Gainsland's test. So what you do is, in Gainsland's test, the hip and knee joints of the opposite side are flexed to fix the pelvis. Okay, the hip joint of the side under the test is hyperextended over the side of the table. Okay, this will exert rotational strain on the sacroiliac joint, and it will give rise to pain. Then you can do an SLRT, straight leg raising test. So the patient is asked to lift the leg up with the knee extended. Okay, so not this. Okay, so knee extended. So you'll just lift the leg up like this. Okay, then this causes pain at the affected sacroiliac joint. You can also do a pump handle test. So the patient lying supine, examiner flexes his hip and knee completely and forces the affected knee across the chest so as to bring it close to the opposite shoulder like this. Okay, so this will cause pain on the affected side. You can also test for cervical spine involvement. So cervical spine may become completely stiff. So Fletch test, okay, Fletchy test may detect an early involvement. So basically, the patient stands with his heel and back against the wall and tries to touch the wall with the back of his head without raising the chin. Okay, inability to touch the head to the wall suggests cervical spine involvement because you can't bend your neck. Okay, then thoracic spine involvement. Maximum chest expansion from full expiration to inspiration is measured at the level of the nipples. Chest expansion less than 5 centimeters indicates involvement of costovertebral joints. Extraarticular manifestations, you can have ocular, so iritis. Okay, they have scarring and depigmentation of the iris. You can have CVS involvement like aortic regurgitation, cardiomegaly, conduction defects, pericarditis. All layers of the heart may be affected. Then neurologically, you can have spontaneous dislocation, subluxation of atlantoaxial joints, symptoms of cord compression. Pulmonary, so again costovertebral joints, it causes restrictive lung disease. So painless restriction of the thoracic cage. You can establish that by using a diminished chest expansion test less than 5 centimeters or pulmonary function test. Systemic, you can have generalized osteoporosis. Radiological examination, so you'll do X-ray, AP and lateral views of pelvis and dorsolumbar spine. So oblique views of sacroiliac joints may be required in early stages. So you'll see haziness, okay, of the sacroiliac joints, subchondral erosions of the sacroiliac joints, sclerosis, haziness, subchondral erosion, sclerosis, and widening of the joint space, bony ankylosis and calcification, and evidence of enthesopathy, so calcification at the attachment of muscles, tendons and ligaments. So you'll also see squaring of the vertebrae, so X-ray lumbar spine. So there is loss of lumbar lordosis, bridging osteophytes, so syndesmophytes, and bamboo spine appearance, so BS in AS, so ankylosing spondylitis. So in peripheral joints, you can see osteophyte formation, periarticular calcification, and bony ankylosis. ESR, HP is mild anemia, so ESR is elevated, HLA-B27 is positive. Okay, so these are other DDs for ankylosing spondylitis, just go through them. Okay, and these are other rheumatological diseases. And treatment, no specific therapy is available. So again, conservatively, you can use drugs such as NSAIDs for pain relief. Naproxen is effective in most cases. And physiotherapy, again, proper posture guidance, heat therapy, mobilization, etc. Radiotherapy in resistant cases, and yoga therapy. Okay, operative treatment, you try to correct the kyphotic deformities of the spine by spinal osteotomy, joint replacement for cases with hip or knee joint ankylosis.